Good evening and welcome everybody to Driving in Dementia, a webinar presented in collaboration with Eastern Melbourne and Northwestern Melbourne PHN, Health Pathways Melbourne, and Dementia Training Australia. My name is Crystal Barbero, and I'm delighted to be your facilitator this evening. Thank you all for joining us. Firstly, I'd like to perform an acknowledgement of country. Eastern Melbourne and Northwestern Melbourne acknowledge the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. MFIN is committed to the healing of country, working towards equity in health outcomes and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them and celebrate their strengths and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services within our catchments. First, just some housekeeping. All attendees are muted. Please use the Q&A box to ask questions. All questions will be asked anonymously to protect your privacy. And a reminder that this is being recorded. Tonight's learning objectives. By the end of the webinar, participants will be able to recall frameworks helpful in assessing and caring for people living with cognitive impairment and dementia, explain the impact that dementia can have on a person's ability to drive, and apply the national driving guidelines when assessing a person's ability to drive. Firstly, I just wanted to provide you with a little bit of background on Health Pathways and our dementia project. As a part of the government's response to the Royal Commission into Aged Care and Quality Standards, primary healthcare networks were funded to develop and enhance the use of existing local dementia care support pathways for their regions. The aim of the initiative was to support people living with dementia to live well in the community for as long as possible. The key objectives were improving the timeliness of diagnosis, increase the uptake of post-diagnostic services and supports, and enhance the ongoing care and support. We did this by providing new and updated content on health pathways, providing dementia education activities to primary health professionals like you're in tonight, and also with the development of dementia consumer resources. Just want to give you a little bit of background on Health Pathways. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways provides clinicians with a single website to access a collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. Navigating health pathways. I'm now going to provide you with an interactive slide to show you just how easy it is to find the resources pertinent to tonight. Here, you'll find our health pathways with local news and pathway updates. You can find the page you're looking for by using the table of contents on the left-hand side, or you can use the search bar at the top using keywords such as dementia. Today, we'll look at cognitive impairment and dementia. The background section provides brief core information. An example here with the onset of younger onset dementia. The assessment section provides a concise list of steps a user may consider to follow at the point of care. Drop boxes throughout the page will provide additional information, links, and resources. For example, assessing cognition using a validated screening instrument, like the clock drawing test. As we navigate further down the page, we'll come to the management section. And give you some pointers. Pertinent to tonight, We'll go down to number 14 here, which is consider the patient's fitness to drive. Here we can link out to our fitness to drive pathway. This one should be used as a quick reference guide. And if we go all the way down to the management section, quick reference guide. Sorry, that one jumped. There was a quick reference guide there, which would then take us out to referral pages pertinent to tonight. My apologies. The other one we also have, just as an idea for everybody here, if you're not aware, health pathways can be used as a tool to help you with your reflecting learning and can contribute to your CPD hours. For both the Australian College of Rural and Remote Medical Practitioners and the Royal Australian College of General Practitioners, you need to complete 30 minutes of a performance review and an educational activity. After completing these, you can use the reflective learning templates and submit them online using the links or via the MyCPD app, which is available on Android or iOS. Quickly here, we have the development of our dementia consumer resource. Firstly, starting off with local directory of dementia. Here you will find local dementia services. You can type in what you're looking for, the service type and the location. The easy to navigate directory designed to enhance dementia support services and resources for all of those living with dementia, as well as their carers and family in and around Melbourne, while complementing the existing directories such as My Aged Care and the NDIS. We also have our wonderful dementia consumer resource information sheets. The Dementia Consumer Resource Information Sheet provides information on what to expect on one's journey with early diagnosis of dementia, questions to ask your doctor, and initial management options. It can be downloaded via our website. It can also be found in the Dementia Directory and through the PHNs. Now, I would like to introduce you to our presenters this evening. We have Dr. Rebecca Moore, who graduated from the University of Adelaide and completed her RACGP fellowship whilst working as an aviation medical officer in the RAAF. She has worked in general practice and urgent care in the UK and Australia and now fosters a special interest in geriatric medicine. She's recently completed a master's degree in dementia. Dr. Peter Steinberg is an experienced GP, GP supervisor, and medical educator. He joined Dementia Training Australia as a medical educator in 2022 and has worked in many primary health sectors. Currently works as the lead clinician at Rekindling the Spirit Health Services in Lismore and as a GP at Lennox Head Medical Centre. I'll now hand over to you.
Thanks, Crystal. And hi, everyone. Hi, Beck.
Hello.
So I love the photos, how they always make me look much younger. Really good. So I'm just going to try and share my screen. So give me a second while I find the one we want. Okay, does that look good, Beck?
Yep, that's right.
Excellent. And now it took off my Q&A. So can you look at the question and answer box?
Yes. Yep.
Okay, everyone. So welcome to tonight's webinar. We are taking questions along as we go, and that's through the Q&A box. So Beck will keep an eye out for them. And we're really excited to be here tonight. We're from Dementia Training Australia, which is different to Dementia Australia. We're federally funded, but we provide education to GPs, particularly in general practice widely, in all matters regarding dementia. And tonight's webinar is going to be on driving and dementia. and we're going to go through a clinical challenge with you and try and tease out some of the details to help you with this challenge. It sometimes feels like a difficult conundrum, doesn't it, Beck? Sometimes when you're presented with this problem.
I think it's one of the most difficult.
One of the most difficult. Hopefully we can try and simplify some things for you and give you some tips. So here are the take-home messages. So definitely begin the conversation early. Nothing replaces taking a good history from the person living with dementia as well as from their carers. And it is often and useful to use more than one cognitive assessment tool. I just noted that Crystal in their health pathways calls them cognitive screening tools. So at DTA, we've relabeled them to assessment tools because technically they're actually not made for screening. Not quite sure how that nomenclature has got into the vocabulary, but they're actually assessment tools, not screening tools. But we mean the same thing. This is mini mental state examination, MOCA, KICA, these kind of things. Reassess driving with capacity frequently, and when in doubt, get help. Ask a friend. Hey, Beck?
Yes.
Hopefully you have one nearby. So before we do our clinical case, we wanted to show you this slide here. So this is a bit of a summary of the trajectory of Alzheimer's dementia. Now, Alzheimer's dementia is the commonest form of dementia, and along with Alzheimer's by itself and Alzheimer's potentially mixed with a vascular dementia, which is common with people with other vascular risk factors and illnesses like diabetes and hypertension, they both account for probably somewhere up to 70 to 80% of all dementias in Australia. And so this is what we're particularly talking about tonight. We're, some of the other more less common dementias that tend to be faster and a bit more tricky, like Lewy body dementia, this talk's probably not suitable for that form of dementia. So you'll notice in this slide that along the top we have what's called stages. And Beck, why have we called it stages and not mild, moderate, and severe?
Well, essentially, I think any diagnosis of dementia for the person is more than mild. And so we use the different terminology, and we feel that using stages gives a sense of progression, but the person living with dementia doesn't have to feel that they're only mild, for example.
Yeah, thank you. That's such an important point. And you've put up the second, one of the second take-home messages of this slide is that, as you know, dementia is a progressive illness. And so as time goes on, things get worse over time. We always get asked the question, how long does it take from the start of a diagnosis until a person dies from dementia? And it's a bit tricky, isn't it, Beck? But what do you normally tell people on average?
Well, again, I mean, the pathology of dementia and the location of the pathology will mean that everyone's quite individual. With Alzheimer's dementia, generally, they say about 10 years. But you'll notice that we do have a left-hand column here, MCI, which is mild cognitive impairment. And so actually that, if you're able to make a diagnosis in this stage, which sort of almost predates dementia, then you could, then the trajectory will be even longer.
Yes, that's right. And so mild cognitive dementia is a term that we use to describe people who are experiencing objective cognitive changes. So it's not just changes that the person themselves has noticed, but that you and other people have noticed or perhaps picked up on your cognitive assessment tools. But there isn't a significant change in function. Okay, why you can see that the function changes are just starting in that area, that's not a significant change. So the person's still able to carry out all of their normal daily activities, like driving, for example, but they may have the beginnings of, they do have the beginnings of cognitive decline. And not all MCI ends in dementia, but there is a subset that's a prodromal phase of Alzheimer's dementia, of those who have MCI, and that's what's represented on this graph here. So just to go over that again, it's a progressive illness that has stages in the diagnosis, and before Alzheimer's is diagnosed, you can have a prodromal phase, which is now called mild cognitive impairment. So the next thing you'll notice on this slide are the colours and these headings, which we call domains of dementia. And the reason why we've done this is because it's really important to think about dementia not just in terms of the symptoms of the changes in cognition. But this is an illness which, of course, when you think about it, given that it affects the brain, it affects the person in all parts of their life, pretty much like any chronic illness. And we've given them 5 large headings. There's cognition, there's mental health, there's function, which is particularly important in this talk tonight. There's physical, and there's behavioural change. And we've got other talks to go over these in much more detail, don't we, Beck? But we don't kind of had time to go over that tonight. But really, we just wanted to highlight the main points about that you have to think about someone in those 5 domains when you're assessing them for driving, and that those domains also decline over time. You can see the lines are going from left to right down for cognition, function, and physical. Mental health tends to be a condition that does waver over time, doesn't matter whether you have dementia or not. And behavioural change, we couldn't quite get the graph right to work out how to do this. I know it sort of goes up, then goes down, but that's they're generally later stages when issues of dementia that can be ones you probably have seen, like more agitation, maybe when someone's speech isn't so good, they might be yelling. But you can also have it in the early stages, like withdrawal and these kind of things. So they're the 5 domains. So this talk, so that's a good sort of overview about the trajectory of someone who has an Alzheimer's or an Alzheimer's mixed vascular dementia. So this talk is about driving and dementia. So if we think about this trajectory, Beck, tonight, right now, and then think about looking at it through the lens of driving, what's this trajectory telling us in terms of how we think about driving and dementia?
Well, I think it tells us several things. Certainly, I think as clinicians, if we're able to make a diagnosis earlier, that can be very beneficial in terms of driving. Firstly, we've mentioned as one of our take-home messages to start the conversation early. And so if we're able to identify a person who's experienced mild cognitive impairment or possibly the stage 1 dementia, we can have those discussions about driving so that people are able then to plan for the future, because it comes as quite a shock, and often the diagnosis is made around that sort of where stage 2 and stage 3 meet, when everything looks very messy, and then suddenly not being able to drive can augment that significantly. So that's the first thing. And of course, people who have mild cognitive impairment and potentially stage 1 dementia may still be able to drive. In terms of the domains, I suppose the other thing to think of is that whilst cognition is extremely important to assess, there can also be changes to function, and that can help us decide on whether somebody is fit to be able to drive still. There will be physical changes, although these do tend to come on later. And also the mental health side of things. So things like indecision, some people can become quite anxious and quite flustered and those sorts of things, and who are living with dementia. And I think that is also important to sort of bear in mind when we're trying to make a decision as to whether somebody is fit to drive or not.
Yeah, that's great, Beck. And then the other take-home message we had was that you need to keep reassessing it. And I think this graph also really, or this picture really helps explain why that is, because it's a progressive illness, and so things change. And so what might be okay today might not be so good in 6 months' time.
Yeah, I agree. And I think, for us as GPs, the dilemma is generally in that sort of middle phase. Usually it's pretty evident if somebody can't drive. And usually if you can comfortably feel that somebody will be okay to drive, then that's actually relatively easy as well. It's that sort of the middle part, that's where we're going to try and give you some tips today to decide whether you think somebody is fit to drive, and if not, what avenues to take.
Yeah, that's right. The other good thing about doing it early is that people still have insight and judgment. And it's such a wonderful moment when the person comes back after initial diagnosis a few weeks later on review, and they say to me, "Oh, look, I've just decided that I think it might be time to hand in my license." And I'm just like, Well, that's made my conversation so much easier in the next 6 months.
Yeah,
So,
that's true.
yeah,
Although not everyone will have insight and judgment, even in
no,
the early stage,
no.
and that makes it even harder.
Yeah. So let's head into our case. So we'd like you to meet Anna. So Anna is 77. She's a retired secretary, and you've just made the diagnosis of stage 1 Alzheimer's dementia with the support of your local geriatrician. And she comes back for review, and her daughter comes with her and says, "Can Mum keep driving?" So this is a little bit about her. So her mini mental state examination was 22 out of 30. And the clock drawing is on the right-hand side of your screen there. You can see there's there was some incorrect positioning of numbers and hands. Her investigations, you wouldn't be surprised to see, are normal because you need to exclude other causes for her changes in cognition, and they were all okay. You did a geriatric depression scale, which was normal, and she's otherwise in reasonably pretty good physical health and mental health. And only other current medications are something for blood pressure and some occasional Panadol. So fairly straightforward case. We understand that you may get more complex than this, but for teaching purposes, we're trying to keep it simple for you. Now she lives alone, but she does have support from her daughter, who you can see in the photo there, who lives nearby. And Anna tells you that the last time she went to drive to her daughter's house, it was raining and she got a bit confused over which instrument was the wiper and which was the indicator. And this actually scared her a bit. And so now she's only driving locally to the doctor to do her shopping to her daughter's. You ask about crashes, of which she's had none, but she does admit to having a few scrapes on the car from getting out of the carport. And she says, although she doesn't drive much, she would be lost without her car. Doctor, you can't take my license away from me, would be a common phrase that I hear. Beck, could you get that one a bit?
It's tricky. Yeah.
So what do you do now in terms of Anna's driving license? So have a look at the screen here. At this stage, do you need to contact the local licensing authority and have her license cancelled with a new diagnosis of dementia? Do you advise Anna that she needs to hand in her license? Do you advise Anna that she needs to go on a conditional license? Do you send her for a driving test with a licensing authority? Do you send her for an OT driving assessment? Or do you send her back to the geriatrician to make an assessment of her driving assessment because you're not sure? So hopefully you've picked the right answer. And the answer is, Beck?
We would say C.
We would say C. And why do we say that?
Well, I mean, certainly when somebody has a diagnosis of dementia, they automatically need to go onto a conditional license. And certainly there are a couple of other options in there that would not be incorrect. I think it would not be totally inappropriate to send her for an OT driving assessment or back to the geriatrician. However, essentially at this stage, we don't need to make any huge rash decisions. And I think changing her to a conditional license at the start is quite appropriate.
That's right, and it's her responsibility as the driver to do that. So it's not a mandatory reporting thing that you have to do as the GP.
Unless you're really, I think that's right. Yeah.
That's right. If you were not in this case because Anna doesn't present like this, but if you had someone who for the first time presented to you in the later stages of dementia and was clearly unable to drive and was refusing to hand in their license, then you have a duty of care to notify the local authority. So these are the Australian driving standards. So, and this is for private license standards, and we'll show you commercial in a second. So it says there that you're not fit to hold an unconditional license if the person has a diagnosis of dementia. Hence that they need to be notified of the diagnosis. And I mean that's all. I'm assuming in Victoria it's all online. I don't know actually. Hopefully it's online. In New South Wales it's all gone online now, which is pretty cool, using HealthLink. And then the conditional license may be considered subject to at a minimum annual review. Now, of course, that might be 6 months, 3 months, but a minimum of 12 months, and you can stipulate what that should be. And you need to take into consideration the task of driving. and information provided by the treating doctor regarding their level of impairment. And it actually lists there the sort of cognitive things you need to be considering. And if you don't do it now, but another time, if you have a look at this, it's actually got quite good information there. And then you may need a practical driver assessment. And you may need the opinion of appropriate specialist. Is there anything else you add there, Beck?
No, that's exactly right, Pete. We've just got some questions in the chat box in regards to the previous slide, actually, just to explain again why C is the best answer and the others are not as correct. And what about mild cognitive impairment? Does a diagnosis of mild cognitive impairment preclude a driver's license?
Question. Yeah. So you don't. So yeah. So my last reading of the at least in the New South Wales driving standards is that MCI does not need to be included on a MCI. You don't have a conditional license just because you have a diagnosis of MCI. The threshold is a diagnosis of dementia. However, if you do have MCI and you feel like the person does have some changes in their cognition that may affect their driving, you can put conditional on there. But it's not the same as dementia where you have to put it on there. Like you do when someone has, now I have to put hypertension, atrial fibrillation, more obvious ones like sleep apnea. They're all listed and you have to mention them.
Yeah, and as you said, it may be that if you're concerned that there is some progression in the MCI, that you might, as one of the restrictions say, requires, for example, a 6-month review on their license. That's an option as well.
Yep.
So just in terms of contacting the licensing authority to cancel the license, well, I think at this stage we have to do a lot more digging to find out, how capable Anna is on the road. It sounds like she's got reasonable insight. She's reduced how much driving she's doing, and she has reasonable insight. So I don't think that's something that we have to do immediately. Similarly with B. And in terms of the driving test with the licensing authority versus the OT driving assessment, we'll cover that a bit later.
So yeah, but the driving test with the licensing authority is basically what everyone has to do when they hit. So I keep saying New South Wales. I'm apologising because Beck and I live here, not Victoria. But when you hit 85, everyone has to have a driving test, like when you get your license at the very beginning. The OT driving assessment is something completely different that we'll talk about in more detail in a second. Does that answer the questions, Beck? Have we covered them?
Yeah, that's right. I think that's fair.
Yeah. And then this is the commercial license standard, and the main difference there is that it's subject to a specialist review, isn't it? And a practical driving assessment.
That's the difference, yeah.
Yeah, so the level, the bar is set much, much higher. Obviously, if you're driving a bus or, like a large vehicle for commercial reasons, then it's a stricter criteria.
Yeah, the assessing fitness to drive details especially are really actually excellent. And so, if there's one section that you read in the AUST Roads, I would recommend the bit on dementia and mild cognitive impairment.
So we've talked about this word cognition a bit, and we're going to briefly break down what cognition means. Because obviously it's a really important part of being able to drive. So if you think about cognition, I think about cognition as I use 2 words, memory and thinking. Memory is one part of it, but it's just an easy way to describe it to patients and for me to think about it myself. And we've come up with a mnemonic. It's not perfect. We've mucked around with a bit. Sometimes we've called it V realms and put the V at the start. Tonight we've got realms with the with the S at the end. So, but basically these are the sort of 7 areas of cognition that you are assessing with someone with a diagnosis of dementia, and a lot of these need to be thought about when you're thinking about driving. So, Beck, do you want to quickly run through these for the?
Yeah, sure. All right. So when we're thinking about Alzheimer's dementia, particularly, probably about 85% of people will present with some change to their memory and their recall, so particularly their short-term memory. Now, obviously, this is going to have some effects on their driving, although a lot of the lessons, a lot of the abilities in driving are somewhat crystallized, they're definitely areas of short-term memory, navigation errors, and that sort of thing. With regards the executive function, however, that's more of a frontal lobe thing, and frontal lobe is really important in terms of the judgment and the insight that we had been talking about. Also in terms of organization and planning, so, you know, each step as it goes with the driving. And particularly if there are sort of external factors like it's raining or it's dark or there was lots of noise or they're tired, there's sometimes the sort of things that will start to flag. Often too, if there's changes to executive function, you'll lose that mental flexibility and that sort of problem-solving ability, which again is quite important in being able to drive. Attention, again, is super important. The ability to maintain focus and concentration, the ability to multitask or to move from one thing to another, and to recognise sort of dangers on the road and make appropriate changes. Also, in terms of the physical side of things, you know, we know that people living with dementia can develop a slowed reaction time as well. In terms of language, I'm not sure how much language is necessarily going to affect driving, but if you're looking at making diagnosis, then things like language fluency and word finding are two things to consider. The motor function, again, we mentioned that Anna was using the muddling up the windscreen wiper with the indicator, and I've certainly heard of stories of a gentleman who got the brake and the accelerator mixed up. And so a dyspraxia is the way that sorry, I've lost
use tools.
The way that we use tools, like the remote control of the television, and certainly there are plenty of tools in the car, and so that's also quite a consideration when you're watching how somebody is when they're driving. Social, again, less important, although it is actually a consideration, because if the person is not able to drive, we do need to be mindful of how that is going to affect them socially. And then visuospatial, which is actually really critical in terms of the driving, to be able to, again, problem solve and judge distances, for example. And so I think in our cognitive assessment, really having a look at the executive function, the visuospatial, is really important.
Yeah, and so I mean they're really good examples you gave of driving, and I think also you kind of need to think in your history that you may have done beforehand about you know, where those areas of cognition might be affecting them too. So, you know, I think memory and recall people are pretty good at knowing what to ask. You know, did you remember conversations from 5 minutes ago, from yesterday? You know, when you walk into a room, do you remember what you came in there for? Do you have to go back inside the house multiple times to collect things because you've forgotten them? Can you remember the shopping list? You know, when you go shopping, these kind of things. Executive functioning, like you say, it's about planning. So you like planning the holiday, you know, planning on going out on the weekend, you know, carrying out, you know, using online banking. Who's doing the banking? Who's doing those sort of more higher level tasks in the brain? And so if motor function, you know, this dyspraxia, you know, like how you're going with the remote control with the TV, how you're going with your phone at home, you know, how you're going in the yard gardening, these kind of things. If people are starting to get confused around how to use tools that they've always used for the last few years, and there's been a significant change in the last 6 to 12 months, and they're not carrying out these higher level functioning tasks like their online banking, and they're not planning their holidays anymore, they're all red flags, aren't they? That, you know, if it's happening in that part of their life, then it might also be really affecting their driving too.
Mm-hmm.
So I think we've gone over most of that. That's the impact of the cognition on driving. So we've got areas in navigation. So again, you know, that could be parking the car, can't find it when you come back. Although I've done that. I don't have dementia, so it's not, you know, you have to take it in context. But you know, that you know, areas of navigation is an interesting one, because if people have always driven the same way for years and years and years down to their local shops, then that's sort of long-term memory. And so, they may still have the skill set to be able to do that, but a new skill set to suddenly drive 2 hours to go to a specialist appointment, that would be not a good thing. So, people can still drive locally, and that can be part of what you decide to. And we talked about concentration, judgment, getting, that mental health stuff can cross over cognition, about getting confused and anxious about making decisions. Often questions I ask the carers is, how do they go turning left and right? What happens when they get to a roundabout? And the concerning answers are, I have to prompt them when to go. When there's a break in the traffic, okay, you can go now. And but they're concerning bits of history that you'd be pricking your ears up about. Talked about poor decision making, slow reaction time, and hand-eye coordination. So I think that covers that, Beck. We miss anything there?
No, that's good.
That's good. So Anna comes in with her conditional license form for you to complete. She's notified the authority. So it's now time for you to make a formal assessment of her driving capacity. What can you do? What can you do next? And this is hopefully where we can give you some more tips. So we definitely say go back to basics, take a history again, and take another history, and then make sure that you have someone in the room who can give you a collateral history. Because of course, if the person is sitting in front of you, their main feature of their dementia is poor recollection and memory, then their history isn't going to be perhaps as good as you need to. So having someone in the room who's been in the car with the person is just a fantastic asset, and you need to use it. If they live by themselves and that doesn't happen, then you're going to have to use other tool sets. An examination, that's what sort of things on examination are you doing, Beck?
Well, I think we need to be mindful that we're not just looking at dementia, and certainly, it's a cumulative effect too, isn't it? So if somebody is having some difficulties with their vision, difficulties with their hearing, they're especially frail, possibly things like peripheral neuropathy, etc., they're all going to culminate and make things even more difficult. So, they're all the sort of things that I would be particularly looking for on examination.
Yep. And then there's the cognitive assessment tools, not the cognitive screening tests, because they're a tool, they're not a test. They're not a test is like sort of makes us think pass, fail. Got to get over 50%. That's not how these tools work. And they're an assessment. They don't screen. They were never made for screening. And that's not their place. So, and we're going to talk about them in more detail in a second. So they're your three things you're going to be doing, which you're probably already doing. Now, this is something you probably haven't seen before, and this is taken from a Canadian study and guidelines, isn't it, Beck?
Yeah, that's right.
So what sort of things do the Canadians recommend we do?
Well, what I find quite interesting and quite helpful actually is this shaft and death mnemonics, and the shaft ones being particularly looking at the instrumental activities of daily living, which are the slightly more complex activities, things like doing the shopping, the ability to be able to get to the shops, remember a list, get what they need, be able to bring it home and pack the pantry appropriately, doing cleaning, doing things like the finances, cooking, organising medications, etc. So they're all things which involve lots of those realms of cognition. And if people are having difficulty performing two of them, it probably is an indicator that they're not really fit to drive. And in terms of the more basic activities of daily living, it suggests that even if they're having difficulties with one of those, that in itself probably suggests that they're not able to function well enough to drive. The other thing to note is that people who are living with dementia, there is evidence that they do have an increased crash risk historically, which is why we have to be so careful. But also their risk of having a crash is greatest if they've already had one. And so a history of crashes is a very significant red flag, I would say. And I do like this concept of the collateral history and making sure that you are talking family members, asking questions like, would you be comfortable driving with this person? Do you have any problems? And if they're saying no, I think, again, that has to be seen as a very red flag.
Yeah, and these are the sort of questions I do on my over 75-year-old driving assessment. So in New South Wales, as soon as you hit 75, you have to have one done every year, independent of your medical conditions. And so they're really great questions. Have you had any crashes in the last year? No, I've never had a crash my whole life. That's good. Anyone at home, worried about your driving? No. So again, you have to take it in context. And this isn't a person living with dementia necessarily, but they're good sort of questions to get a bit of an idea of what's going on. But I love the box. I'm not sure about the death mnemonic, but we'll go with it. Shaft and death. So I love it, the fact, because if you think about that, you look at the one on the left, you go, well, medication management. Okay, so they're forgetful with their taking their tablets, and we've got a Webster pack. That's a common thing you might do with someone with dementia. But they're still pretty much managing, that other stuff on the side there. And, they can still dress themselves and go to the toilet themselves and hygiene. I mean, that'd be pretty common, right? We've helped them, supported them in building some structure around their cognitive changes, and to keep them at home and to keep them doing what they want to do in their life. But they're still managing there. But when they get to the stage where, okay, well, we started with the Webster pack, but now they can't cook, prepare a meal anymore. That's a pretty significant change. Or suddenly they were doing all their banking, and now they're, making mistakes in the online banking. That's a red flag. And then you throw in another one like, oh, they just need a little bit of help, with getting dressed sometimes, or there's a bit of wandering, or they're much more unsteady on their feet. You can see how it's a mix of those things together that's a red flag. So hopefully that's a new thing that you haven't seen before as a tip.
Yeah, Pete, I'd like to just say that the family can be extremely important in the history, and I feel often very reassured when they say, "Oh no, they're absolutely fine." That's very reassuring. But do be mindful. Sometimes there are sort of ulterior motives. Definitely, yes. Sometimes the spouse is reliant on that person to drive.
Yeah.
And there I have seen it too, where the family is quite keen to inherit dad's car, and so you do just have to.
You have to be careful. Yeah.
Be a bit mindful.
Yeah.
The other thing is just in our chat box. There's a question here: at what age we should consider MCI assessment? What would you say to that, Pete?
I don't have an age for that. I generally will do an assessment for someone's cognition, thinking about MCI, when they either come to me voicing concern, or I've picked up, signs or symptoms. Essentially, they've either, said, oh, I'm worried about my memory, or I've, because I know them well, I've suddenly going, gee, why is your diabetes management suddenly gone off when it's been stable for years? Or maybe you're not taking your tablets. Yeah, so I don't have a particular age. I don't know. What about you, Beck?
Well, I think, look, there are some red flags, which probably is for a different day, but certainly people who experience hearing loss, I think they're the sort of people that I might be keeping a closer eye on. Anyone who has significant risk factors. There are some demographics where the onset of dementia is younger, and we do know that our Aboriginal and Torres Strait Islander population does tend to develop a dementia earlier, and so I think that, again, it's probably worth just being on the lookout for this, more around the 50, 55 age. And as Pete says, as a part of the over 75s health assessment, there usually are several questions there. And a lovely geriatrician once said to me that if you notice a change of 2 in an MMSE, or, as we used to do in our over 75s health assessment, then that would sort of trigger a deeper dive, essentially.
Deeper dive, yeah. Yeah, I work in an Aboriginal medical service, and the guidelines for the annual health assessments, which you can basically do from birth. But once you get over 50, there's now an added screening, now an added question around memory and thinking. How's your memory and thinking? Do you have any concerns? Do your family have any concerns around memory and thinking? And that's a good sort of non-sort of judgmental way of introducing the topic.
Yeah.
That's a good question. We digress. So we
Sorry.
better keep going. So we talked about the physical exam. So you talked a bit about that, not of course, don't forget vision and hearing. And then with the cognitive assessment, we're going to do that now. So particularly we talked about things like processing speed, task switching, visual, spatial, and executive functioning. That's around planning and complex tasking. So how do we do that? So which one of these cognitive assessment tools are the least helpful in assessing Anna's driving capacity? So least helpful. Hopefully it's not too controversial, Beck. We'll see how the question out box lights up. But we've got MMSE. So why we said that's the least helpful?
Well, there's a few reasons. So, firstly, the people who have a higher educational level tend to perform better on the MMSE. And so often people can have significant cognitive change, but still score quite well. So that's number one. Number two, the MMSE doesn't cover sort of as many domains of cognition as some of the other ones. And particularly we're mindful of things like executive function, task switching, and visuospatial. And so that's where the clock drawing sort of has more of an element of problem solving and visuospatial. The trail making bee, I think, is probably the best one because that has elements of all of those things, as well as task switching. So the intersecting pentagons alone, if they did an MMSE but struggled with the intersecting pentagons, again, that would make me sort of do more tests. And then the maze test is fairly evident that would be quite helpful in driving.
And we're going to explain what they are in a minute. At my practice, when we do the MMSE, we always add on a clock drawing task, a clock drawing task as well. So that's obvious. That's something that we've added to our repertoire, which is quite helpful too. So let's go through this in a bit more detail. So these are the tools that we think are very helpful. And again, it's because they use these visual, spatial, executive function, attention aspects of the cognition that are most likely to be aligned with the skill set you need when you're driving. So there's the Trails B, which we'll show in a minute, the Snellgrove maze test, the clock drawing test you'd be familiar with, and the intersecting pentagons. So this is the trail making B. So what have you got to do here, Beck, when you can just print these out online from the web fairly easily. So what's the instruction task?
So they will come with a smaller task, and generally what I do is I actually do it and show them. And so you're going from number to letter. And so when I'm explaining the task, I show them, I explain it once, and then I give them this bigger task. Now, if somebody does it in less than 2 minutes with less than 2 errors, I feel very comfortable that they're fine. If they take longer than that or they make several errors, I think, again, that sometimes when it's a bit intermediate, and if they take longer than 3 minutes, that usually indicates that there is something a bit more significant going on. But again, it's not just one diagnostic test. I mean, there are a whole host of reasons why somebody might struggle with the trail making bee that are not dementia related. But for the purposes of this talk in driving and dementia, then I think using the trail making bee as one of your decision aids is really important.
Yeah, and again, it's not. I like how it says they're probably unsafe. So I have an example where I have someone who has dementia, and they came in for their license, and we did a trail making, and they were more than 3 minutes, multiple errors, and much to their annoyance, I requested that they did an occupational therapy driving assessment, and they passed. So I was a bit surprised, but there you go. You know, like I wasn't in the car with the person for 2 or 3 hours like the OT was. So again, it's probably unsafe. It's not fail, you cannot drive, give me your car keys. That's a really important principle.
Sometimes anxiety, people can become quite anxious, although again, that's something that can happen with driving too.
Yep. These are the Snellgrove maze tests. This is a fun one to do. If you haven't done these before, like print them out and just do them with your family at home or with your registrar of medical students, it's quite useful just to have a go yourself. And again, easily obtained online. And again, there's a scoring system around timing and the number of errors. So similar concept, just a slightly different validated tool. We talked about clock drawing tests. I don't think we need to spend too much time on that, but you can see there that as cognition declines, the clock face also deteriorates. This is a favourite of geriatricians. They love this one, and I love it too. And what I recommend you do too, that if you can, is my nurses are really good at helping me do cognitive assessment tools and clock drawing tests, and clock drawing tasks and stuff. But I try and get them to do this one in front of me, because watching the person gives you a lot of information about how quickly they fill in and where they put the numbers and how they order them and putting in the time. And this is your intersecting pentagons. And you can see A is pretty good, and as they go down, they get more Picasso-esque and more concerning in terms of being able to carry out a driving task. So we got any questions about that on the chat line there before we...
So there are two questions that we haven't answered yet, and one is pertinent, I think, for now. Can tests like the trail making and draw the clock test be learned by patients after after being repeated? And that's a good question. I think if you are doing these things irregularly, then it's fair. But yeah, certainly there can be that that possibility that there is that learned response. So yeah.
I'd say if they were smart enough to look it up before they got in there and practice it 10 times before they got in the room, that's a pretty good sign.
I have had patients tell me I've been practicing my cube. But yeah. No, I mean, with the MMSE too, there is a risk that people have somewhat memorized the answers.
Yeah.
So I think it's a fair question.
What was the other question, Beck?
The other question is that given that cars are becoming more complicated now to operate, for example, Tesla doesn't even have indicator stalks, will cars of the future make it too complicated for most patients with dementia?
Oh, I hope it's the opposite. So I hope the cars become, autonomous. How good would that be? People with disabilities, people with dementia. I'd so happily just get in my car and let it drive me home, and I'd read my book or go to sleep or whatever, be on my laptop. I love that. I know some people the opposite. My partner loves driving. She'd be like, no way. I like to be in control. But yeah, I mean, it's a good point. Again, I think it's about learning new tasks. So, like if someone has stage 1 dementia and they suddenly get a new car, like that probably wouldn't be so good. Well, I'd say that would be bad, actually. Yeah.
And that might unveil some concerns from family. But we will talk shortly. We're running a bit out of time, but the OTs, not only can they help with driving assessment, but they can also help enable people to continue driving. Yes. And maybe there might be some elements of digital technology that can be assistive. For example, I think one of our colleagues has a person living with younger onset dementia, and he has a special navigation tool, actually has a restriction on his license that he have someone in the car with him because he was getting lost and that sort of thing. But the OT was able to help make some plans to enable him to continue driving.
So that's right. So here's the checklist. We've gone through all this. Take a photo of that if you haven't already got one. But they're the sort of things you could do. You don't have to do all of the cognitive assessment. You don't have to do trail making and clock face and intersecting pentagons. But if you could do one of them and think about the Canadian guidelines too. So that's a really useful checklist. So hopefully we've given you better tools there. Beck just mentioned OT driving assessment. So this is considered to be the gold standard. They spend time with the person before the test, they do some cognitive, assessments themselves. They make sure that the person's safe to drive before they get in the car with the person. And that's one of the other reasons why, if you're worried about someone, don't send them to just for a standard driving test, because that's not particularly fair on the driving instructor. And again, this can be actually enhancing rather than taking away. as Beck said. The main barrier with the OT driving assessments is access, particularly in regional and rural areas, and cost. I don't know what they're like in Victoria, but in New South Wales, they can be up to $1,500. But, you know, like as one of our geriatricians who does talks with us says, driving is not a right, it's a privilege. And the way I've sold it to people is, look, I know you want your license and it's really important to you, and I understand that, and it could be, you could be completely fine to drive, but from the assessments I've done in here, I have some concerns, and I've got to, you know, like I need to make sure the public's safe as well. And, you know, part of you having your license, just like your registration and your insurance and the upkeep of your car, is going to be having this OT assessment.
And it takes 5 hours, like it's quite an extensive process. So
that's my sell pitch.
Yeah, I think that's fair. And the other thing, so it takes 5 hours, so it is quite intensive. And also I think for that person who's really quite reticent to be giving up their license, I think making them aware that they're going to need to do this and probably need to have it repeated, you know, at various reviews. I think that, again, just starts to get them thinking about what am I going to do if I'm not able to drive. You know?
So these are for the people that Beck talked about in the very beginning who are in that grey zone, not the people who are in later stages where it's very obvious they shouldn't be driving, or the people in the early stages or in MCI that you now feel confident with our talk and doing your own assessments that they're okay, and, you know, getting a collateral history, they're okay to drive with review. These are the people in the middle where you're like going, oh, geez, I'm a bit worried here. And I think they're okay. And you do some assessments like I did with my lady, and they're not scoring very well. And you just want some, you know, you're a doctor, you're in the GP room, you're not sitting in the car. So this is where these are very, very useful. We've got 2 minutes, Beck. So planning for driving. So we've talked about that conversation earlier, getting people involved, talking to someone about what the driving means to them before you do the assessment is a tip that one of our colleagues does, you know, to find out, you know, how independent they are, what would it mean if they lost their license, and what's their emotional attachment to driving in their car. These conversations can be helpful. There are some things that can assist, like the taxi subsidy schemes, community transport. You know, if you live in aged care villages, sometimes they have transport to go shopping, these kind of things. Obviously, again, rural and remote communities, driving has greater significance when there's less access to support. Oh, and there's the last slide. Excellent, Beck. 7:29. Well done. So any questions that we haven't answered before we finish up?
No, none on the chat at this point. Oh, hang on. No, let me see, different chat.
Last chance.
All good.
All good. Well, hopefully that's given you some more tips. Remember to begin the conversation early. Take a history, especially collateral if you can. Be mindful of what Beck said about, you know, what might be going on with the family too. Try and use more than one tool. And it is something you need to keep reassessing, because it is a progressive illness that needs to be checked every 6 to 12 months, maybe 3 months even. And when in doubt, get help. That could be an OT assessment, or it could be back to the geriatrician and getting them to help you out. All right. Thanks, Crystal. I think that's back to you.
Perfect. Thank you so much. And thank you, everybody, for attending this evening. It's been a pleasure to have you all here, and I hope you've taken away some valuable insights about driving in dementia care. I'd also like to extend a special thank you to our presenters, Dr. Rebecca Moore and Dr. Peter Sternberg. Thank you so much. It was extremely insightful. By participating in tonight's RACGP accredited activity, you'll receive 1 hour of educational activities, which MFIN will lodge on your behalf. At the end of the session, the survey link will appear on your screen. Please provide your feedback, because we'd love to find out what you've got to say. If you haven't done so already, please register via the QR code on your screen there for our next session, which is Medication Management in Dementia, which is being held via Zoom on Thursday, the 22nd of August at 6:30. And we've also got a QR code there for you to register for Health Pathways Melbourne. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you've seen tonight, in addition to other relevant resources. You will also receive your certificates within the next 4 weeks of this session from Enfin. Thank you all for your time and attention tonight, and have a lovely evening.